The stab of punctured wounds usually caused by force delivered along the long axis of a narrow or pointed object like knife or sword into the depth of the body. The depth of the wound is usually larger than the length and width of the wound in correspondence with the shape of the sword or knife, and it's subdivided into penetrating or perforating. The penetrating, there is an entry wound to the body and there is no exit wound, in which the object enters the body cavity or enters the skin, creating a path of entry without leaving the body. And in case of head and neck injuries, penetrating injuries, we should check or search for upper airway bleeding from an injured blood vessel or fractures of spine. And penetrating wound, we should check for any foreign bodies, and careful debridement should be performed also as an abrasion and laceration. While perforating wounds, there is a through and through wounds, meaning that there is an entry wound and exit wound. Usually the exit wound corresponds to the tip of the penetrating object like the knife or sword, which should be narrow and everted, where the wound edge is everted outwards, and the entry wound usually larger and with inverted edges. So if the object is removed from the body, we can differentiate the entry wound from the exit wound. Like this. Here is the sword. There's an entry wound which is larger, and while it enters the body there is inversion to the tissues to inside, inverted and larger, while the exit wound there is eversion of the tissues to outside with smaller wound at the exit. Other forms of injury includes crush injury and avulsion injury. In crush injury, there is severe trauma where the body is crushed between two heavy blunt objects and the edges of the wound are rigid and with varying amounts of devitalized tissue with or without tissue loss. While the avulsion injury, there is a significant tissue loss with part of the body is being avulsed out and can be considered as a very severe form of abrasion where all the layers of skin are torn off and the underlying structures are grossly exposed. And there may be a complete loss of a small body part, such as the eyelid or fingertip or part of the ear, and also may be caused by animal bites. There are injuries to tissues caused by heat, friction, or electricity. Heat may be in the form of dry or wet one, and both cause damage to the all or some of the skin layers according to the degree of fire or duration of exposure. Of course, it's highly painful due to exposure of the peripheral nerve endings and requires specific treatment distinct from other injuries depending on the degree of burn. Burn injuries can be classified to 4 degrees, first, second, third, and fourth degrees, according to the extent of damage of tissues. The first degree is confined to the epidermis, with associated clinical severe pain, dryness, and redness of the skin. And second degree usually extend deeper to the dermis, and here is the tissue or skin is moist and red, which blanches with pressure, and blisters may form. While in third degree, the entire depth of dermis, not part of it, is involved, or the full thickness of dermis, and they are considered severe injuries with resulting skin being stiff and brown. And here is due to damage of the peripheral nerve endings, the pain is not a common feature. In the fourth degree burns, there is charring of skin due to the effect of deeper structures like fat, muscle, and skin is dry or black and painless. Heading to the management of soft tissue injuries, management usually starts with selection of the accurate diagnostic procedures to manage or to confirm the diagnosis of the condition for proper management or to explore any associated injuries with apparent clinical evident soft tissue injury for proper management. Clinical examination starts with inspection with consideration of the anatomy of the affected area, including any nerve, duct, or muscle injury, followed by palpation for any bony fracture or foreign bodies, and the site suspected should be compared with the normal non-affected site for comparison. Deep lacerations posterior to the vertical line at the lateral canthus of the eye may involve facial nerve or parotid duct, and the periorbital soft tissue should be evaluated thoroughly, including the cornea, globe, or lacrimal duct injury. Timing is very critical in the definitive care, either we're gonna manage immediately or delay till infection or acute infection resolve. Supportive therapy include antibiotics to control infection and analgesics to control pain, with or without high protein diet and high fluid intake, surgical intervention, and finally post-operative wound care. The timing depends on the complexity and extent of the other facial injuries, and the definitive treatment should be within 24 hours, while in complex lacerations may be delayed up to 2 days. In case of delayed definitive treatment, like in complex lacerations, all wounds should be thoroughly debrided, irrigated, and hemostasis achieved, and a dressing is placed and moistened and changed day after day till complete healing. Supportive therapy, as we said, include the antibiotics. The first line usually the penicillin, unless the patient is allergic to penicillin. We prescribe penicillin and an anti-tetanus therapy for soil-contaminated wounds. And in case of patient previously immunized, half milli tetanus toxoid booster is given, while non-immunized patient 250 units intramuscular of tetanus immunoglobulin and plus tetanus toxoid 0.5 milli at once and after 2 and 6 months. The surgical intervention may be performed under local or general anesthesia with or without regional block and infiltration anesthesia for hemostasis according to the extent of the injury. And the local anesthetic agent should be injected carefully to avoid disruption of the soft tissue outlines. In the post-operative care after management of the wound, dressings have different advantages, like perform pressure on the wound and stop bleeding, causing hemostasis, and it could utilize topical antibiotic just in case needed, or antiseptic ointment, and frequent changes mandatory to avoid infection of the wound, and this dressing also protect the wound against trauma or infection. Hyperbaric oxygen can be utilized for post-operative wound care to increase the pressure of oxygen at the target area. Hyperbaric oxygen therapy involves inhalation of 100% oxygen at 1.9 to 2.5 atmospheric pressure for sessions 90 to 120 minutes. The dives or sessions may be performed once daily or 5 to 6 times per week. It supplies the tissue with all the metabolic requirements and oxygen required for proper wound healing for 2 to 4 hours after the termination of the therapy. It also induces new blood vessel formation or angiogenesis, which in turn increase or prompt the wound healing better. It enhances also the fibroblast and leukocyte function to fight infection. It aids in the healing of chronic, complicated, and non-healing wounds, which is the main target for the hyperbaric oxygen therapy. The clinical improvement for the wound healing can be noted after 15 to 20 sessions of this treatment. The hyperbaric oxygen chambers may be individualized for one person or large chambers for many persons or patients. So the specific considerations during wound management involves number 1, hemostasis or controlled bleeding to avoid formation of hematoma which invite infection, debridement of all devitalized tissue, necrotic tissue, or foreign bodies to avoid tattooing or infection of the wound, repair in either single or multiple layers according to the anatomical structure for proper repair or healing, and consideration of specific structures in the area like any lacrimal duct, parotid duct, nerve, blood vessel, etc., as we described earlier. Hemostasis, as we said, invites wound infection and may cause wound breakdown, and the source of bleeding must be identified and clamped if it's large blood vessel, or cauterized if it's small blood vessel. Management of bleeding to avoid hematoma formation can be accomplished with either local anesthesia with vasoconstrictor to constrict the blood vessel, application of local hemostatic agents, or local pressure on the bleeding artery. The intermittent versus continuous suction. The continuous suction usually stimulates bleeding, so intermittent is much better than the continuous suction. And systemic measures like vitamin K injection or supplementation of the factor missed from the patient, like anticoagulant factor if the patient is deficient or have a hepatic problem. The coagulation factor missed should be identified and supplemented. Second most important after hemostasis, debridement or toileting of the wound using a surgical scrub brush or soap cleansing and foreign body removal. High pressure irrigation also remove bacteria and foreign body efficiently, more than the regular irrigation system. The devitalized tissue should be removed conservatively, not aggressively, to leave sufficient tissue for proper or primary wound healing and to freshen the edges. The facial soft injury should be managed as early as possible, and the primary closure is preferred. And basic principles during suture: number 1, precise approximation of the wound margin as much as possible without tension, as tension causes strangulation or constriction of the blood vessel and necrosis of the. In case of eyebrow injury, minimal debridement of wound involving the eyebrow is necessary without shaving the eyebrow hair, because it doesn't erupt again, and it should be closed primarily with interval hair graft from the posterior scalp for aesthetic reasons. In eyebrow injuries, detection of any injury supraorbital nerve is necessary and required management or repair is performed. In case of eyelid injury, careful assessment for globe injury should be performed before the eyelid repair, and eyelid lustration should be closed in layers, as we said before: the mucosal layer, muscle layer of the tarsus or the eyelid, and finally the skin layer, with careful approximation of each layer, muscle, conjunctiva, and tarsus. For deep sutures within the eyelid, the node should be directed away from the globe to avoid its trauma, and any tissue defect in the eyelid more than 1/3 or from 1/3 of the eyelid should be restored or managed with either partial lateral canthotomy, as we will see before, to mobilize the lid medially to facilitate primary closure, or another type of flap. Here is lateral canthotomy is performed between the upper and lower eyelid, and reflection of tissues is performed. Here is after resection or during management of trauma to the lower eyelid from 1/3 or more of its length. After lateral canthotomy, the lower eyelid is mobilized to attain primary closure of the two wound edges, like here in the final view. For nasal injuries, skeletal alignment is sufficient to realign the soft tissues, and any illustrations of the nose may involve skin, nasal cartilage, and mucosa, and the repair should proceed from the deep layer mucosa to the superficial layer, mucosa, cartilage, and skin. And careful inspection for the development of any septal hematoma or hematoma of the cartilage of the nasal septum. This hematoma should be drained to avoid perforation of the septal cartilage. For lip injuries, as we said before, complete cut of the lip. We should perform 3-layer approach by closure of the mucosa first, then the muscle layer, then the skin layer, with alignment to the vermilion border to avoid stiff deformity of the upper lip. In other situations, for defects larger than 1/3 of the lip length, like avulsion by animal bites or cancerous lesion resection, defects more than 1/3 of the lip, local flap provide better outcome than primary closure, like I've said later. Here is carcinoma of the upper lip resected with safety margin, leaving a defect of 1/3 of the lip length. A similar flap dimensions is performed on the lower lip, and then the lower flap is rotated to cover the superior lip defect and left for complete healing, connected to the lower lip to maintain the blood supply of the flap rotated. Then after complete healing, this pedicle of the lower lip flap is separated and the incision is resutured and the tissues are aligned together. Here is another case of lip carcinoma where a safety margin is performed in a rectangular fashion. Then incision is performed in the lower lip in a step ladder form to allow the flap to be mobilized upward to cover the defect. In case of intraoral soft tissue injury, the amount of soft tissue should be assessed well if the wound left behind can be managed primarily by primary closure, or it requires a local flap to avoid disfigurement after closure. Another thing is composite defect composed of skin, mucosa, and bone. Free tissue transfer is preferred from another side of the body for reconstruction, depending on the extent of the defect also. And injuries to the buccal mucosa should be carefully assessed for injuries of stencil duct or papilla. As we said before, deep injuries to the cheek along the vertical line proximal to the lateral canthus of the eye usually almost involve the stencil duct. And in case of the duct injury, the edges of the duct buccal is reapproximated with fine sutures of a polyethylene stent, which is left in place for 7 to 10 days. If the gland is injured itself, the whole gland is removed with duct ligation. Here is lacrimal duct injuries should be considered in case of injuries involving the medial canthus of the eye, and this injury is assured by operative microscope, and the repair is performed like an extension duct by approximating the edges over a silastic catheter or stent, which left in place till complete healing for 3 to 4 weeks, and it should extend through the entire lacrimal duct system to the opening of the duct into the nose to provide adequate drainage of the secretions of lacrimal gland till complete healing. Regarding facial nerve injuries, the buccal branch facial nerve is the most commonly affected with the stencil duct of parotid, and this is usually happen, as we said before, in injuries anterior to the line attaching or approximating the lateral canthus of the eye. And this injury doesn't cause permanent loss of the muscle function supplied by the buccal branch facial nerve due to the distal branching of the facial nerve. And in case of its injury, the cut ends are debrided and approximated by microsurgical neurography or ligation of the nerve index. And in case of large gap or defect between the nerve index, nerve grafting or cable grafting from a specific nerve, or even a neural tube is approximating both ends of the nerve to direct or to guide the nerve during healing from one end to another to restore continuity and function. Here is the lacrimal system and lacrimal duct. Here is injury medial to the medial canthus of the eye involving the lacrimal system. A catheter or stent is inserted from the medial canthus of the eye through the whole lacrimal system till it's the opening or drainage into the nose to allow healing of the duct ends till complete healing with prompt drainage to avoid blocking of the drainage and infection. Here is in case of unilateral facial nerve injury, which control the muscles of facial expression. One side of the face has no expression due to injury of the branches of the facial nerve, while the other muscles are mobile normally. Here is the branches, terminal branches of the facial nerve: temporal, zygomatic, buccal, mandibular, and cervical branch. Here, as we said, in case of gap or defect between the nerve index or the nerve injured, the most common graft site from the sural nerve from the leg, because its diameter is compatible with the facial nerve, or from the lateral or medial antebrachial cutaneous nerves from the arm. These three sites are the most common graft sites from which a piece of the nerve is harvested to augment or graft the facial nerve defect to restore function. Here is another option other than the nerve grafting, is the placement of neural tube to guide the nerve endings to meet each other till complete healing in the mid. There is different designs of tubes for nerve regeneration. Here is the stages of wound healing. Start with the inflammatory stage, with invasion of inflammatory cells and white blood cells, red blood cells, and lymphocytes. Then fibroblastic stage, proliferation of these cells for healing, and it lasts for 2 to 3 weeks. And finally, modeling stage. The inflammatory stage begins with vascular phase, where is the initial vasoconstriction to control bleeding inside the wound, and then followed by promoting blood coagulation by the release of histamine and prostaglandin E, which in turn cause vasodilatation and leak of the plasma and leukocytes to migrate into the interstitial tissue where the wound exists, with fibrin that causes lymphatic obstruction and edema. And usually the cardinal signs of inflammation from this phase is redness, swelling, warmth, hotness, and loss of function and pain due to edema and swelling. The vascular phase is followed by the cellular phase, as the trauma to the tissues stimulates the serum complement system, which in turn attracts the neutrophils to the site of injury. The neutrophils start to stick to the side of blood vessel, then migrate, and when contacting foreign materials or microbes, they release their contents of lysosomes, and the lysosomes undergo degranulation, and the enzymes released from the lysosomes destroy and digest the foreign body or bacteria.